Good afternoon, everyone. Thank you so much for taking the time to join us today for our May Share.Solve.Evolve webinar. Today's topic is on safeguarding the guardians' mental health awareness for the public safety telecommunicators community. We have a great list of guest panelists today. We have Jim Marshall from the 911 Training Institute, Michelle Lilly from Northern Illinois University, April Ford from Springfield Greene County 911, and Kevin Lessard from Northern Middlesex RECC. Before we get started, before I turn you over to our host today, Jeremy DeMar, if you have any questions, please use the Q&A feature in the top panel of your Microsoft Teams user interface. If you write your questions, we will address those at the end of today's webinar. So without further ado, Jeremy.
Thank you, Marie, and good afternoon, good morning to everyone. Really appreciate all of you being on the session today. And I've been accused in the past of saying I'm super excited about things quite a bit, but I am absolutely super excited to be hosting an all-star lineup today. Most, if not all, of these names in the 911 profession are people that you know, and if you don't know them, you're going to know them very, very well by the end of the session today. But let me begin by introducing myself. My name is Jeremy DeMar. I'm a senior product manager for Intrado. Prior to my time with Intrado, about 30 years in the public safety space, the last 20 of which on the public-facing side of 911, which is frankly where I met these four fine folks that we're going to be talking to today. So again, before I go too much further, just from a logistics standpoint, I'd like to kind of explain to folks how we do this and how we lay it out. First of all, the Share.Solve.Evolve webinar series is designed to bring in subject matter experts and professionals from the 911 space, both on the public and private facing side of 911, to talk about all things 911 and any issues. And of course, we felt it was appropriate this month to talk about mental health awareness because it is Mental Health Awareness Month. So we have some very knowledgeable, very well-skilled, very well-known folks to come in and talk about that today, and super excited to do that. So generally by introductions, I usually go by the way these folks are laid out on my screen. They can't see how they're laid out on my screen, so it's always a surprise to see who I'm going to go to first. So I always ask them to be prepared. And in this case today, April, you are on the far left-hand side of my screen. I'm going clockwise. So we're going to start with a brief introduction from you, if you wouldn't mind.
Sure. My name is April Ford. I am the director at Springfield Greene County 911 in Missouri, formerly the director of Jasper County Emergency Services in Carthage and Joplin, Missouri, and I've been doing this for 27 years. So very excited to be here.
Awesome. Thrilled to have you, my friend. Thrilled to have you. By the way, I'm just going to put a quick shout out there. April just recently completed graduate studies with the Naval Postgraduate School, my alma mater, of course, for graduate studies. So I'm super excited and super proud of April for her work. She continues to do amazing things for 911, but I, for one, can tell you the challenge of completing graduate studies, and it's no small feat. So kudos to April for getting through that program, and super excited to have you as a member of the alumni there. So congrats.
Thank you.
Awesome. Kevin, you are next in my counterclockwise. So we're going to go to Kevin next.
All right. Hello, everyone. Thanks, Jeremy. My name is Kevin Lessard. I'm the executive director at the Northern Middlesex RECC. That's located about 25 miles west of Boston, Massachusetts. We are a center that serves two communities, about 62,000 residents. And I've been doing this for 18 years now, full-time, 911 dispatcher, supervisor, now executive director. Happy to be amongst this great group of people today, and excited for the conversation. Thank you.
Thrilled to have you, sir. And you guys didn't catch it. All of you that are viewing didn't catch this prior to. We always meet as a group prior to kind of talk through some things. But the weather that just passed by me in Springfield, Massachusetts is now over in Kevin's neck of the woods. So we're hoping we get to keep him for the entire session today, and that doesn't make things go too crazy. But thanks, Kevin, for being here today. Dr. Lilly, you are next in my counterclockwise rotation.
All right, so we didn't even get a heads up of being on deck. Thanks, Jeremy. But I am prepared. So I'm Michelle Lilly. I'm a professor of clinical psychology at Northern Illinois University. I've been there since 2009, which is crazy. I'm a licensed clinical psychologist in the state of Illinois. I have APIT licensure to practice across state lines. I was trained through the VA to do evidence-based treatments for PTSD, depression, anxiety. I do training, I do some consulting, do lots of different things in the 911 space, but also work a lot with police and fire as well.
She's kind of a big deal, folks. I'm not going to lie. She's kind
Stop
of a big deal.
Stop it.
Michelle and I had the opportunity to actually do a speaking session with Brad Flanagan on incident-related imagery at NINA SBP this year, and I thought it was exceptionally well attended. We got a lot of great questions, but super excited to have Dr. Lilly here contributing to the conversation today. So thanks for being here. Mr. Marshall joining us following a couple of technical difficulties. How are you today, sir?
I'm great. Can you hear me okay?
Yeah, but your video seems to be seized up unless you're really good at remaining still. So,
well, I'm just a little bashful today, so because I'm in the austere company of all of you folks there. So that I'm glad to be with everybody. And this topic is, of course, near and dear to my heart, both on a personal level and as a professional. I'm a licensed mental health professional, master's clinical psych in Michigan. I've been practicing since 1987 and in the trenches with 911. I began training in 2005. 911 Wellness Foundation, nonprofit, 2011. And 911 Training Institute was co-founded by my sister, Debbie, the dispatcher. And I fell in love with the 911 population many years ago. They haven't kicked me out yet. I'm kind of like the weird uncle to Michelle's weird aunt, if you will. And glad to be a part of this, Jeremy, to see what good we can do that might be lasting for people today.
And super thrilled to have you here, my friend, and hopefully your video feed will come back up again. But for now, the still pose that you have is not too bad. It looks pretty good. A lot of times when your video gets hung up, you're like, boy, could it have gotten hung up at a worse spot? But you look pretty good, sir. So we're gonna hope for the best at this point. So again, just want to talk to all of you. And for those of you joining Share.Solve.Evolve for the first time, we try to keep it pretty candid. It's just some casual back and forth. It's not scripted. We did as a group last week, which I do with all of our Share.Solve.Evolve folks, talk about a few of the talking points that we wanted to get across today. But I do want to encourage all of you, and Marie is operating in the background, kind of fielding things. I'm trying to watch chat as we go along as well. But if there are things that you want to talk about, or there's questions that come up during the course of this, feel free to drop those into chat. If we don't get to it today, we'll definitely make a point to follow up with you, because all four of these folks are just a wealth of knowledge, great information. And the unique thing about today's session, this is one of the first, you're going to get the perspective from folks that are on the public facing side of 911, in April and Kevin, and then of course on the, I don't even call them vendors, but industry partner side, supporting 911, in Dr. Lilly and Jim Marshall. So I'm real excited about it. So let's jump right into it. So some of the things that came up in our preliminary conversation, and there were a variety of topics, when we talk about mental health and wellness, as a whole for the entire 911 industry, we could go a variety of different directions with this. But Kevin and Dr. Lilly, I'm not going to put you on deck, but just be ready, because it might come to you after this. But Kevin, I kind of want to start with you, because one of the things that you talked about, and I would encourage, by the way, Jim, Dr. Lilly, and April, weigh in as we go here. I'll try to watch for your hand wave, but just chime in. Kevin, you had an interesting thing that you talked about, because one of the things that stemmed from our conversation was the unique perspective of newer folks that are joining the 911 profession, just coming into it, super excited. It's a brand new venture for them. But you had an interesting perspective, because you said what you try to do as a leader is try to take on a little bit of what that new person might be thinking when they come in. We know the work-life balance piece is huge, especially when we talk about generational differences and those kind of things. But one of the things you said, which was, what is my agency doing to help me, kind of resonated with me, because I think for the longest time, especially those of us that have been in the business for a while, we were kind of always under that blanket of, oh, well, I'm glad I've got a job and they're keeping me around. But that has shifted a little bit. We've definitely seen, especially in our younger generation, a willingness to leave if things really aren't feeling good for them. They won't sit around. They won't tolerate as much. So can you expand a little bit on that statement, that what is my agency doing to help me, and what are you doing in your agency to address that?
Yeah, of course. Thank you. It's kind of front on my mind these days. The wellness part, learning what is going to keep people around. Our retention rates are are struggling in 911 centers, mine included. So when someone says like, oh, well, that's happening in the industry, nope, right here too. It's just because, people are, when they're younger, looking for something to start off with, or have maybe been in the job world, working professionally for a little bit. They want to have a mentality that, the agency is looking out for them. And that's something that we've struggled through and that we've built upon and made sure that new people are welcomed in. I have an orientation day with them when they first start, almost a full day to go over, yes, of course, you cover policies, procedures, but to say, this is what you're coming into, this is what we're trying to help you out with. And one major initiative that my group, my dispatchers and supervisors even proactively looked into was what kind of wellness days or what kind of mental health assistance do we get, more than just the standard programs that exist that insurance provides. And one thing that happened this year through bargaining, of course, through the procedures with the group, is that they're now given 2 wellness days every fiscal year after they see basically a licensed clinical professional offline, out of work. They need just to see them for at least a full session one time, and they'll get an 8-hour, like basically vacation day. It's used as that, and they're going to get 2 a year to start off with, and we're going to evaluate it after a year and see if we can even increase it from there. And it's just a small gesture, a small thing that even came organically through the group, through my center. Looking at all the different standards that are out there, of course, but something that we implemented that has resonated well and boosted morale, I think, for those that have been looking for something like that for quite a while. So that was a nice thing for us.
And I heard you say you're part of a collective bargaining unit, right?
Correct.
Okay, so much like a lot of the folks that are on the session today, myself included, both when I was running from an operational standpoint as a supervisor and certainly as a director, all 3 of my centers were all union shops. So you're absolutely right. A lot of these things that we're trying to do, especially when you get into a director or a leadership role, we may feel that they're, awesome, incredible opportunities for our folks to really take advantage. But we do have to go through the hoops sometimes with our union folks to say, hey, what I'm trying to do is a good thing. So, but I love the fact, speaking to the union side of it, that you're making those 2 wellness days available to your folks the minute that they start, because a lot of times historically with unions, oh, well, you got to be here a year before you can take advantage of that. And you're making those things available, right out of the gate, which is awesome. So Dr. Lilly, I gave you a warning, so I'm going to come to you now, kind of dovetailing on what Kevin talked a little bit about. One of the other things that came up in our preliminary conversation last week was about EAP. And EAP, I often said, is that evil 3-letter word that gets thrown around quite a bit, especially when somebody in our profession says, oh, I'm having difficulties dealing with this, or I dealt with a bad call. And we see so many folks, leaders in the profession, throwing the EAP card saying, yeah, go call these people. But what truly happens in that situation? And you raised an interesting point. You've kind of tailored a slightly different approach to deal with this, because frankly, the reason I was so intrigued about what you said was because I don't think a lot of directors, a lot of leaders, a lot of managers really know what to do beyond the EAP card. So maybe you could talk a little bit about the services you were chatting with us about.
Yeah, absolutely. Yeah, I it's so funny that you say that, because literally just this morning I'm writing a report for somebody, and it's actually law enforcement, but it was like 72% offer an EAP, and 17% have actually used it. Right? People do not typically use EAP for lots of different reasons. That could be a whole hour webinar right there. So we won't go into that. Just as a quick side note, 15% of people actually trust their EAP in that survey. Right? People for lots of reasons, don't always trust their EAP. So something that I've done with a number of different agencies is set up a retainer services. So as a licensed clinical psychologist, I work with a number of agencies where they set a certain number of sessions per month that people can reach out to me. Their employees reach out to me directly. They do not go through their employer at all. I set up times to meet with them. And the agency is given no information other than on a quarterly or 6-month basis, how many sessions have been used. So they can increase or decrease the number of sessions, but they are never provided information on who, what, where, when, what was discussed. unless it was, if there's like criminal activity or something that they have to know, then of
Right.
course there are some limits of confidentiality. And the response has been huge. I work with one village, for example, they have 10 sessions between their police, fire, and 911, and almost every single session, if not more, every single month is used. And it's not just
Awesome.
the same people always using it. It's different people reaching out. Sometimes they pop in for a session or two because they've had a difficult call. Sometimes it's people who I meet with on a semi-regular basis. If it becomes too much non-work related, I've been asked to kind of refer those folks out, but then I try to find them a good home for somebody to see. And in every case that I've worked in these retainers, kind of getting to your original question about trainees, I kind of say you need to open this up to trainees. And through that, in the past year, 18 months, there have been 2 trainees from 2 different agencies who have reached out because they've had some early exposure to some upsetting calls. And they said, I don't know if this is for me. And we focused on their coping. We talked about how to process these things, how to increase their longevity. And both trainees made it out of training, and are now working very successfully in 911 independently. So I think sometimes when people have those early distressing experiences, they attrit, right? Or they leave, or they just start white knuckling it. But the more that we can help people early on recognize when they are having those reactions and what to do with them, we could maybe retain more of these trainees.
Yeah, no, that's awesome. And, I think the fact you talked about that 15% mark that are comfortable using EAP, but based on, and I'm not sure exactly the metrics or the numbers that you've got, but based on the number of people that seem to be, getting involved in those services that you're providing, it sounds like your numbers are considerably better than what's going on with EAP. So kudos to you. And people talk, right? I mean, when they get in, they have a good session. And again, this might be with you, or this could be with anybody. In fact, I'm going to go to April in a second, so I'm giving you the heads up. But when folks are interacting with somebody that they're comfortable with and they can trust, they're going to go say, hey, you got to go do this, or you got to, what's the old saying? People don't really brag too much about what they like, but they love telling people about a horrible experience. Even with those numbers, it's likely that there's people talking about the great experiences. So thank you for that, Dr. Lilly. That's awesome. April, I'm going to go to you next. In fact, I think what you and I talked about first when we met last week was you talked about covering a certain number of visits for your folks. And I think this in a way kind of ties in with what Kevin's talking about, but I was hoping you could expand a little bit about some things that you've done to try to really kind of do the same thing that Kevin was doing and that what Dr. Lilly has offered.
Sure. And this is in my former agency. So my current agency, just to make sure everybody knows, I've only been here for 9 months and we work for a municipality. So it's a little bit different here in the city where we do have EAP, and that is pretty much it. I haven't explored what my opportunities are there because we're city employees and we're not collective bargaining. We are not union here. So I'm still learning what I can do. But in my former agency, we were a political subdivision, and we had the opportunity to contract with a local group of clinicians. And so what we did was we did 6 visits. Initially, it was 6 visits per year per person if they wanted to use them. And then it kind of migrated over to 6 visits per incident per person. And when we set up the contract, we contracted a rate that we thought we could afford. We gave ourselves a number, we set up the budget, and it was really beneficial. What we found pretty quickly is that it wasn't being utilized. And so we had to really start educating our people. And then another thing that we found pretty quickly is not every clinician was culturally competent in public safety or 911. And so we had a couple of instances that really kind of went south and created some hard feelings for them going back to that one clinician. So I had made contact with the director of the group and said, these are the only clinicians we want to use because they are culturally competent in 911 and specifically public safety in general. And that's kind of how we moved forward from there. It worked out really well. And I would say something else that Missouri did, it was the CIT Council who actually came together and brought some clinicians together for the state of Missouri for a one-day meeting. That was all things about public safety for the clinicians that were interested in becoming more culturally competent and being able to serve all areas and aspects of public safety disciplines. And it was really great and a great opportunity to just sit and talk and have a QA session with clinicians that would either be available by phone or were in person if you were close to them or willing to drive to them, or they were willing to drive to our PSAPs or agencies. And that's, a lot of those clinicians were not in our area, so we kept with the contract that we did have with our local group. But it was really more about making sure, like Kevin said, that your culture within your center identifies that mental health and wellness is extremely important, and making sure that your people understand that you can't leave it at the door when you leave work, and you can't leave it at the door when you come into work. It's no longer that environment. We have to be mindful of that. And so I think that really helped us. Yeah. Like I said, in my current agency, that's a walk I have to figure out how to get down. But I think it's something that's worthwhile, because on those EAP programs, although they're an amazing opportunity for them to be utilized, and it's something they're available, especially if they're going through something in their personal life. And we know public safety wise, we have a lot of that goes on. We just need to make sure that there's some clinicians that know what we do for a living and understand, and don't go right to, you should quit your job. Because I've heard that from my family physician multiple times, like, you're under too much stress. You need to find another group. That's not going to happen.
Yeah, especially when you've got a lot of tenure in the job. I mean, you can't, sure, we'd just love to go, I won't mention any stores because I don't want to get in trouble, but we all talk about being the greeter, handing out smiling faces. And it's like, okay, but that's not always an option for all of us. But the fact that you're taking progressive steps like Kevin to do these things and to make these services available is terrific. And number two, that's why professionals like Jim and Dr. Lilly are so critical, because these are folks that truly understand what's going on in the profession. It's not just, oh yeah, it's a blanket understanding and we're going to come in and no, these folks are absolutely skilled specifically in what goes on, not just in public safety, but in 911. So thanks for that. Thanks for that, April. Jim, I'm going to come to you now because, and this ties in perfectly. One of the things that you mentioned in our opening session when we were talking about this was vetting EAP. And the reason I thought this was great, and again, I just want to put this out there. I recognize, certainly as a former center director and being a part of a center for 15 years where I was a supervisor, that EAP in some cases is better than nothing, right? I mean, it's better than not having an option. So I want to make sure everybody understands I'm not picking on EAP, but I also think some of the points raised during today's conversation, and certainly what Jim's going to share with us, these are valid points and things that as leaders in this space wanting to take care of our people, we really want to consider. So I was hoping, Jim, you could expand a little bit about your thought on, have you vetted your EAP and what you think folks should be looking at?
Right. Well, so first, there's a difference between just ripping on EAPs, which no one wants to do as a concept, but we have to have a standard of practice. And in the country, we have not defined a standard of practice. However, we did in the 2013 NENA standard to protect the well-being of non-professionals. Actually, the title of it then was the Standard on Acute Traumatic and Chronic Stress Management. Now in 2022, as of 2022, we have the standard to protect the well-being of non-professionals. Kevin, I think, made reference to that. He had consulted our standards. All that is to say that our directors aren't necessarily going to know, because they're in a directorship role, what the criteria should be for an employee assistance program to be acceptable for delivering services to our people. We provided a best practice guidance document, and that's available on our website. This is not for charge. This is a document that's available at 911training.net, www.911training.net, and just go to resources. The resources tab, and you'll see EAP best practices, and that can be shared in the chat or whatever information you folks provide after this. But the point being that we have to articulate what those standards are. One of the things that we need to begin with, and I'm sure Michelle has lived this as I have, and as it's tremendous where April and Kevin have lived this from your side. You made reference to a couple that went south because they weren't culturally competent. Well, this is tied to the low approval rating of in willingness to use the EAPs. Look, number one, we just need to be clear that employee assistance programs are not there to deliver treatment for complex psychological problems. There's a rare exception that they have clinicians, for example, who are using evidence-based treatment for trauma. We don't have traumatologists typically on EAPs, employee assistance programs. The EAP is there to provide support for adjustment kinds of problems, challenges, maybe sorting some things out with family, with our job, or relating to our jobs, managing basic stress. They should be prepared to equip our people with more coping strategies to problem solve, brainstorm, etc. However, when we're looking at treatment of bipolar disorder, post-traumatic stress disorder, major depressive disorder, generalized anxiety disorder, these are generally not things that in-play system programs are prepared to do. So our agency needs to know, step one, vet your EAP using standards such as we provide for you in that document that I gave you, and then respect their limits in terms of what they don't provide, what they're not designed to provide. So then the question becomes this, and I know we don't want to add more work to directors' plates, but there's two kinds of work our directors end up doing. It's cleaning up messes, or it's the work to prevent messes from occurring. And so one way they can prevent a mess with EAP is to take the standards that we're providing you in that document, request a meeting with the director of the EAP, the clinical director, and if you've shared the document with them, they've read it, and to say, can you honor these standards? Are you? If you're not, what can you do to meet those standards? If they're not capable of meeting those standards, then I believe our directors need to seek other alternatives to EAP. Michelle provides this example of having a retainer with agencies. First, you have to find clinicians as capable, maybe not as capable as Michelle, because she's living and breathing our 911 family, as I am, but we need to, that's just true. I mean, we don't need people who are we do need people who are basically culturally competent, as you said, April, right? So number one, we've got to be able, if our EAP is not working, we have to have clinical alternatives in the community. They need to be vetted as well. They need to be culturally competent. Number two, we need those clinicians in the community in addition to EAPs, because EAPs are for basic problems and not for complex challenges. So set the standards, meet with EAP, vet them, challenge them. And I know that most of our directors are not the ones who hired or created the contract with their EAPs. They were basically gifted with EAP from county, whoever purchased them. I say gifted with a lowercase g in many cases, but they may need to come back and say, this is not working for our people. We have to get a better EAP, either provide us with the ability to do it on our own, as Michelle is proposing, like with retainer, or let's get a new EAP for the county.
Yeah, and
that's it.
No, Jim, and that's all great points. And in fact, we do have a lot of other material to cover, and I'm constantly watching the clock because I want to get to these other things. But I think this is worthy of mentioning as well. And certainly in the first center that I was a part of, to your point, the EAP was established by the overarching municipality, right, by the city. And that by default extended to all city agencies, one of which happened to be the 911 center. So yeah, the basic levels of EAP might be perfectly fine for those folks not operating in a high stress workspace like we are here. But to your point, yeah, I think that vetting process, part of that needs to be getting them on the phone and saying, hey, look, I recognize you're the contracted provider for this municipality, the city, whoever it happens to be, but what is your expertise relative to, if not 911, public safety as a whole? Because a lot of these folks should be coming back saying, oh yeah, we've done this or we've done this. And if they're like, well, we don't really have any specific things that we can cite, that for me as a director, as a leader, that raises some red flags, because inevitably what's going to happen is you're going to have some catastrophic incident that occurs. And every one of us, you and Michelle, certainly from a support standpoint, and April and Kevin, from an operations standpoint, and myself, we've all had that bad call where we knew we were going to have at least one or two, if not a bunch of our people having access to these resources. So I think it's hypercritical that we talk about that. So excellent points, though. I do want to go to Kevin next. So I'm trying to kind of maintain some degree of organization. So Kevin, let's go back. Let's circle back. I made a couple of mentions initially to the generational side of this, and I'm going to mention the R&R, the recruitment and retention problem that's facing 911 across the country right now. I don't think it's any shock. A lot of centers are in that 25 to 30% down category. In fact, there's a couple of close colleagues of mine that are directors in other centers in the country who have told me, yeah, we're fully staffed. And I'm like, I don't know if I'd be shouting to the rooftops too much about that. Somebody might come after you, but most of the centers out there are not fully staffed, and they're having troubles not only retaining the staff that they have, but attracting new talent. But a big piece of that, of course, is the generational side of this. And in our pre-call last week, Kevin, you talked a little bit about that mentoring health and wellness, and you talked about it here as well, but making it part of the onboarding process. I know one of the things that I did as a director was on day one, and I think, Kevin, you hinted to this a little bit as well. On day one, I always ask my training coordinator, hey, can I have maybe an hour or so with our folks just to kind of, first of all, thank them for being here and tell them they're in the most important public safety profession out there. Make sure they understand that. But then to explain kind of some of the logistics and those kind of things. But beyond that, what are you doing now to really let your folks know that mental health and awareness is one of those critical aspects, in addition to all the other things that they have to know? What are you doing to better prepare your brand new folks for that?
Yeah, it's a big concern of the other staff, right? So the CTOs, the training officers, the supervisors, and those that are in leadership. My chiefs that I work with, my operations committee is always asking or really sharing things that they're adopting within their policing and fire industries. The professions themselves, like what are people doing? Because it's affecting us directly with people that are coming in without really a knowledge about what programs exist, and informing people that, okay, yes, we have the EAP. Yes, we have a new wellness policy / wellness days to take. We have things that we're offering for their staff development, things that will enhance them to make them want to come back when they have those, double overtime shifts where things are like, oh, I just need some time off. And new people also don't get it's a big problem. A lot of people, when they start out, don't get a lot of time to take off, and time is really critical to them. They don't care enough about the money. Yes, the money's great. Money's helpful for things, young families, of course, but people want time. They are saying to us, what are we doing about recognizing that aspect of, like, maybe I'll be good after a nice 3-day weekend. Working shifts, working weird schedules and rotations. I mean, everyone can throw out what they have, and you'd get 5 different answers, honestly. I think that is something that we've tried to look into more. Again, meet with those people at the beginning, check in with them, make sure that, yes, they're following their training program and the training policies are being adhered to. And that they move through their different shifts, but even preparing them for that, like saying, hey, you are going to work midnights. You're going to work these weird hours. They're going to have a health, degradation of your health at first. We try to assist them through some of those challenges, and just be recognizing as administrators and as directors that you have to think about that. I need to think about that more, and I'm always learning.
Yeah. No, and excellent points. And Dr. Lilly, I actually want to ask you, in light of what Kevin's talking about here, my feeling, and again, not having your background specifically, especially as it pertains to mental health and wellness, but my feeling is, certainly as a former leader in that space, the earlier I can introduce the idea of, hey, we're here to support you, to your newly appointed staff, is a good thing. But I want to ask your opinion on this. And I'm actually, you guys see me looking down, I'm taking notes as we go along, because, if my wife were here, I forget stuff all the time. But how early, in your opinion, how early should we be having these conversations with our new personnel? I mean, we know that as new folks come in, it's that information overload, right? I mean, we're throwing everything at you in a very short period of time, and in some cases, centers around the country have actually abbreviated their regular courses of training to get people streamlined, to get them into the system faster. So is it appropriate, in your opinion, Dr. Lilly, that we're having these conversations about mental health, wellness, those kind of things right out of the gate, or should we be waiting until a little later in the process so as not to overwhelm them?
Yeah, I mean, there's already so much information, right? So you're trying to learn and absorb all the stuff, and then you're like, oh, and by the way, this might be really hard for you emotionally, right? It's not the best message. But I think the earlier that we can be giving people messages and tools to manage the distress, the better, right? So, we know, for example, a long-standing coping strategy among first responders is avoidance, right? Kind of avoidance coping, suppression, ignoring it, just kind of
deny,
suppress, right? Which makes sense, because you have to. I always say, first responders, you have to be masterful at avoidance coping, right? Because in the minute, if you're upset by something I'm telling you as I'm calling you for help, and you start to cry, I'm not going to feel very good about your services, right? So you have to develop the ability to suppress your emotions. It's critical. But when that becomes your kind of primary or only method of coping, then it becomes a problem, because we know that avoidance coping, when people kind of suppress, deny, don't process things, they really do accumulate over time and have impacts. And so I think the earlier that we can give that messaging to people is critical. So, around the state of Illinois, I've done a lot of training with law enforcement. And so there's been some discussion about coming into the academy, and at very early, right? If they're in the academy, not a full day course, because first of all, they don't have the time for that. But just some of that early messaging, and then maybe offering people kind of developmentally appropriate training, right? Because the challenges that you have as a trainee are not the same challenges that you have when you're 5 to 10, maybe 15 years in, and all of a sudden you have a family, and now you have little children, and now you're taking kid calls, right? And you have kids. It's a different challenge than when you're then later, approaching retirement, and you have this cumulative trauma, and what is the role transition? So the stressors and things that can, I think, be distressing to you kind of change over time. And I think we need to be acknowledging that and starting early.
That's a really cool thought too. And, again, we joked in our earlier session that this might spin off into 15 different sessions because we only have an hour today, but you raise another valid point. I think back to the first center I was with, where I spent, the first 15 years of my career, how many people during the course of that 15-year period got married, had children, got divorced. I mean, all these different life experiences, right? And you're right. Each one of those situations is going to have a uniquely different impact on the person and what their needs are and what's going to be going on. So that might be another good topic going forward. But I love the fact that you mentioned that. Thanks, Dr. Lilly. April, I want to go to you real quick on this as well, because again, one of the things you talked about was the regional peer support team. Now, the center I was a part of, we had a peer facilitator team, I think along the lines of accomplishing what you're doing with yours. But to the point you made during our conversation, you said here, it can be difficult due to not wanting to talk to your own personnel. I would absolutely agree with that. I think there were folks that certainly from a director standpoint, I appreciated that they made themselves available. But at the end of the day, I'm John Q. Dispatcher, and if Jane Q. Dispatcher happens to be my peer facilitator on duty, am I really comfortable sharing kind of my thoughts and feelings? I mean, I'm a guy anyway, so I got it all figured out, right? I don't need anybody's help. But am I certainly going to have some reservations about doing that with somebody that's a member of my own team? So I love your thoughts about the regional team and the reach that the regional team has and what it accomplishes. So I was hoping you could talk a little bit about why that's important, especially where you are.
Sure. So in Kansas City, we have the Mid-America Regional Council, and Pam Opaka is on this call. She has developed a regional peer support team program that teaches all about peer support resources, gives PSAPs and ECCs the ability to go back and have somebody within their organization that is a peer supporter, that's trained, that has people that they can count on throughout the region that they can talk with. And so I'll back up to my former agency and then my current agency. We both, my former agency and current agency, has peer support teams. In my former agency, prior to the Joplin tornado, we had a CISM team. So we had a group that was trained. We were trained out of Tulsa, Oklahoma, to perform debriefings, diffusions for our own people, and we kind of collaborated with our local public safety disciplines. Some of them used chaplains, some of them didn't, and that seemed to be okay. But it just never really always hit where it needed to hit. Sometimes you don't need to send somebody to a debriefing. Now diffusions, I would say something totally different, because we saw during the tornado that was extremely helpful. But sometimes people didn't need to go to the debriefing because they might get more vicarious traumatization from the other individuals who were involved heavily in the event. And so when we started ours as a peer support team at Jasper County, we kind of went out and went to peer support conferences and started to learn and get educated by other states that were having conferences. And then we found out about the Mid-America Regional Council's program that had a regional peer support team, and we sent one of our peer supporters from our agency through that team and that training. And it was an amazing opportunity for us to look outside the box. So we were already going to other states and looking outside the box, but we weren't thinking about, during our tornado, we couldn't possibly help our own people. We were all, affected by it. But after the tornado, we had a lot of other things that happened. Officer involved shootings and in the line of duty deaths, and even down to I had employees who were really struggling deeply. And as a director, even though we know we're not responsible for them, we're responsible to them. We take responsibility because they're a family. And so I was able to, as a peer supporter myself, but even if I wouldn't have been a peer supporter as a director, reach out to a team member who was in a totally different county, totally different community through the regional peer support team, through the assistance of Pam. And we had other people who were able to do that, where I couldn't talk to my own team about the struggles that I was having. And I didn't want to talk to another director who might not see it the way that I needed them to. I needed them to be out of the box with me, and they might get in the box with me, if you know what that means. And so that regional peer support team was extremely helpful. And I just think, and where I'm at now, we have a peer support team, and I'm starting to work on the collaboration here locally, but also wanting to send somebody through that regional team training program as well, so that we can have the same opportunities here. So my people have the same ability to reach out to somebody who is understanding, because they do the same job, but they're peer support trained. I think you have to collaborate with your local agencies, with your local other first responder disciplines. And if there's regional teams, or if there's not regional teams, start them. It is nothing for neighboring jurisdictions, and even in my former agency, and even here at Springfield Green, for us to have gone and helped supported a neighboring jurisdiction whenever something bad happened. Yeah. And they appreciate that, because sometimes when it happens to you, you just don't feel like you're seen. And speaking to a clinician, even if it's somebody who's culturally competent, is a very intimidating thing for a lot of us, especially those of us who've been around for a really long time. And I'm definitely not afraid of it. The tornado made me jump over that bridge, but it's so helpful to have those other people who do the job that we do, just be there for you and support you and understand and be trained how to support you, but also not know who you're talking about whenever you're talking. They don't know.
And I'm sure, yeah, and I'm sure many of us can point to circumstances where something like this would just be ideal. And I think the other side of this, and Jim, I'm going to go to you in a second, but the other side of this is making sure that you have the appropriate MOUs or MOAs in place with your neighboring agencies, that the policies are well understood. So again, we're not waiting for something horrible or horrific to happen before we're like, oh, what's that number again for this? These should all be things that as leaders, we are sharing amongst each other and knowing full well how we're going to activate those if and when the time comes. So Jim, thanks for that, April. Jim, I want to come to you really quick. First of all, I want to give you an opportunity to comment on what Dr. Lilly, Kevin, and April just said. Then I've got another question for you.
Sure. Well, first, I'm gonna embarrass Pam Apoka from Mid-America Regional Council. There's a reason that the 911 Training Institute awarded her with our annual award for outstanding peer support contribution. And I'm giving recognition right to her, because these are things, when folks do things that can be replicated by others around the country, we're helping everyone, even beyond our own service area, and that deserves a recognition and credit. And having said that, then, when peer support is being done properly, trained properly, designed properly, implemented properly, there's always going to be the element of mutual aid, because as has been said, the fundamental deal is we can't treat ourselves. That goes for clinicians, it goes for peer supporters as well. And so when we're all impacted by the same high impact event, whether man-made or natural disaster, we need the support of other agencies. So now when you think that 70% of our comm centers in the country are rural, we take the principles that Pam practices, but we have to be able to implement those across rural areas and states, parts of states. So in the states where we build teams and train teams as a training institute, we are supporting not only the training of individual comm centers and their peer support teams, but that mutual aid model and supporting them in building out statewide networks. So our Georgia is one of those who got ahead early, and other states are following through, Tennessee, Alabama, and many others. So that's absolutely critical. I'm going to offer one other thought here, and then you can harass me however you want, Jeremy. and that is, let's tie this together. What was said about new people coming in, and how soon do we talk about these things? I'm just going to say this. Give me 60 seconds on this.
Yep.
We need to begin with all of these issues, these concerns about supporting mental health in our comm centers, with the embrace of the directors and their board of governors behind them, saying we prioritize this. The director then needs to offer strategic messaging, and if there's been a conflict or a lack of investment in this in the past, start by owning the shortcomings. Start by owning transparently that, you know what, we have not been all together about this in the past. We're all here to learn. We're all human. The leaders need to proclaim the investment in the care of their people. It can't be left to the peer support teams. They need to be brought along by a strong impetus of proclamation of the priority on this by the leaders and their governing boards. So then when we talk about new people, we do need to let them know right away, but not to scare them away. We do need to say we are sharing responsibility by, number one, telling you these are the risks that you face, people at varying levels, and we need to be invested in equipping you. One of the reasons we invest in training and do training in the industries, because if people are not trained, as Michelle said, to manage these stressors, it's unethical to put them in the seat. So, but when we can say from the beginning, we're going to be real about the risk and we're going to empower you so that the resources match the demand, rock and roll. Let's go.
So let me ask you one more question, or I want to ask a quick question of all four of you. A simple yes, no. You don't even need to explain it. Just give me your opinion on it. Those centers, those agencies that are not already including a comment in their job postings about the stressful work environment, these kinds of things, the things that all of you have talked about. Yes or no, centers should absolutely be including something in their job postings that talks about the stressful nature of the job if they're not already doing that.
Yes.
Yes.
With qualification.
Yeah, I agree.
Kevin, Dr. Lilly?
Yeah, I think it should say something like, must be able to handle working in a stressful and fast-paced environment.
Kevin?
That's exactly what it is.
I was going to say that's what I have now, but I
Okay.
definitely want to think about expanding that a little bit because I think it's going to be important for me to make sure I'm on the right path as you guys. But I think we're on the right.
Yeah.
All right. Well, let me do this. I got about 12 minutes left, and I have so many more questions I want to ask you guys. But I'm going to go back to Jim real quick. Jim, removing the stigma, right? This phrase gets thrown around so much, and I think Dr. Lilly was talking about it earlier. Certainly for me, I was in public safety for 30 years, but 10 years into my 30-year tenure in public safety is when I joined 911, and it was still very much running rampant at that point. Tough it out, deal with it. If you need, you just did CPR with somebody on the phone, or, you pulled a drowning kid out of a pool, or whatever it happens to be, take a walk off the floor for 5 minutes, come back and be expected to do your job. That's the way it was when I started. Now I've heard significant improvements, not only in the center that I used to work for, but certainly the two centers that I oversaw. But are we effectively, is the word removing the stigma, is the idea that we're removing the stigma really truly happening? Is it becoming more acceptable to say, I'm having a difficult time with this? And are you, as a clinician, and certainly as Dr. Lilly, are you guys seeing as many folks coming out saying, hey, I really want to talk to somebody, more so than you were as recently as 10 years ago? And I'll let you go first.
Yeah, there's a definite sea change. There's a lot of improvement. However, having said that, we have cultures within enclaves of different states where you go to Washington, I was there completely. Yes, we're all into mental health. Go to some of the areas in the East Coast, and some are invested in mental health and the stigma is being dissolved. Others, not at all. It's very much still old school. Wow. What it comes down to break the stigma is that those who've been through hell survived it because they invested in their self-care and in getting professional care, need to be vocal and tell their story. Those who are respected and veterans tell their story. It's one of the most powerful ways we can break the stigma.
Love it. Dr. Lilly?
Yeah, I think just being very clear, and it starts with leadership, right? So I think especially folks who have, been raised in the same family, it's kind of it can be hard to break mold. But yeah, I think starting with leadership and just being clear that this, to me, as humans, we connect most through our suffering. So it makes perfect sense why sometimes these calls are really upsetting to you. That actually makes you human. And so I think kind of spreading that message and saying, of course, there's going to be calls that are pretty distressing, and you might have some nightmares, and you might have some some ripples over at the next couple of days. That actually makes you human. That's your brain trying to make sense of what happened. So I think the more that we can kind of normalize having reactions to difficult calls, the better.
Love that. Love that. Kevin, you're already demonstrating, with your with some of the things that you're doing with your group and the services you're making available, you've embraced the remove the stigma. But are you seeing this as well? Do you see that some of your folks, and maybe even folks from neighboring centers that you're hearing about, are they coming to you maybe not as concerned about letting you know that they have issues with in these areas?
Yeah, I think we've had success, but also we've had some struggles too. It's like We've tried to offer assistance to people after, the critical incidents that do occur and following the guidelines of those teams, but making sure that people just are aware that they can reach out to them. And again, bring in a regional team and a statewide team, whatever that exists, whether we built it or not ourselves intrinsically. That they can reach out to and offer or get resources for. We've seen both sides of it, and I think it's a growing concern for us as directors and leaders.
Love that. And your camera seized up there for a second, Kevin, but you came back to us, so it was all good. Okay. Thanks. April?
I would agree with Kevin, and I was going to kind of mirror what Dr. Lilly said. I mean, we as leaders, and it doesn't matter if you're the director or your supervisor on shift, we need to identify our people that we do recognize they're human and that we are also human, and being transparent. I know that there's certain things we can't say, but being transparent is important. And so if you have gone through a disaster yourself, we have to remember where we came from. And it is okay to share that information with people. And it is okay to open up and say, I am not this dispatcher on a pedestal. I am the person who can actually go and say, I need some help. And I think that gives them the ability, you have some humility, you're showing them you're human, and you're letting them know it's okay to be human themselves. And it's something that you guys said. I mean, we right off the bat take our peer support team in and do training, but I do feel like that is it's something that needs to come from leadership, that we need to be right there with the peer support team saying this, we recognize that this is a very difficult job and we are supporting all of this. And so everything that we're doing for you to make sure that you're resilient so that you can be there and care about the caller and care about your agencies.
Yeah, that's awesome. I do want to allow some time for a quick question or two at the end of this. So, but there's one more thing I want to add before I go to Marie for questions. We are seeing some unique ways in which center leadership across the country is doing different things to make not only make resources available to their personnel, but some out of the box thinking about how we can make the work environment less stressful. And I see April starting to smile. I think she knows I'm coming to her with this, but we talk about comfort dogs and some of these things, but comfort chickens. I mean, I want to hear a little bit more about the chicken situation. So if you could just share that quick before we go to Marie.
It's not my current agency, but my former agency, which is my family. So shout out to any of my family members who are on here, work family. They had the great idea. So we would bring our dog in from the county. The sheriff's office had a comfort dog, and even though our board wouldn't let us have a dog full time and have a handler, we would bring Charlie into the center to run around. Everybody could get on the floor and play with them. But we also have some people there who would bring their dogs in on Fridays. We knew their dogs were good, safe to be there, not going to bite anybody or pee on the floor. But after I left, they hatched chickens. And they got to name the eggs, put them in an incubator. And we had tried fish, a frog. I don't know what happened to the frog. The fish died because we were on well water. We were talking about doing some type of lizard or something. And I left and they were like, oh, chickens. And it is amazing. I love that they did it. And I went into the center not too long ago and they had one chick and I was like, oh my goodness, that's so noisy. But it was the cutest thing. And it was so cool to see the eggs that were not hatched had names on them. They literally named their eggs. I thought that was amazing. I came back to my center where I'm at now and I was like, we should hatch chickens. I think it's something cool you could do. And especially if your agency is not into like a dog or, anything like that, it's just some thinking outside the box, giving them something to look forward to, something fun, something to watch, something to be involved in and engaged with, I think is the coolest thing you can do for your people.
Kevin, you're laughing. You're going to have chickens and lizards before too long. I know it's happening.
I'm just saying not dogs and chickens at the same time, because that's a recipe for disaster. I don't care how well-trained the wellness dog, the therapy dogs are. I have many friends that are handlers of those. I don't know how they
seriously. Yeah, I think it's amazing. It's the creativity that counts, right? It's not the specific.
Yes,
it's the creativity.
What an incredible program, Jim.
We are running very close on time. Marie, I want to come over to you for a second and see if we have any questions for the panel before I go to them for final comments.
We do. We have a question from a guest. What are some good EAP programs out there? We had one, but you had to wait months to get help when our people called in.
Anybody want to I see Michelle's eyebrows going up. Michelle, you want to go first?
No, I don't. I'll be honest. There are some, right? So like when I've gone and done trainings, for example, in Texas, like they have a couple like very robust, good EAP programs. But in terms of like nationwide good EAP programs, I'm not aware of any. But I could be wrong. I've never run a center and been looking for these services.
Yeah, we featured an outstanding peer support program in the book, and if this person would like to contact us, info@nowintraining.net. I do have some information. The leader there at that center, a clinician, they really have created a best practice model, and I think it may have been replicated by a number of the others who participate. It's not, I don't know that it's a national organization, but it may be. So if they want to reach out to us, give them the information for that individual and see if they can follow up.
Yeah, and I would only add to this, and I'll give Kevin and April a chance to respond if they want to, but I would only add to this, our profession, especially those of you that are watching today that are newer to the profession, our profession is one where sharing is a big part of what we do. And I wholeheartedly, I mean, I would have people reach out to me as a director all the time and say, hey, do you have a policy for this? Or how do you do this? And vice versa. I would have to reach out to others and say, what are you guys doing? So we're big on not reinventing the wheel. So if there's something successful that's working in some capacity, somewhere in the country. I mean, Nina has different forums, APCO has different forums where you can reach out and ask people, or, reach out to Jim, Michelle, Kevin, or April, or myself, and we can put you in touch with somebody. So there's a huge network in the 911 space that loves to help one another. So I would definitely encourage those of you trying to figure this out and sort through it to reach out and ask. April, any comments on that before we go to closing comments?
I would just make a quick comment and say, not only thinking about when you're looking at EAP mental health, but also think about financial health. A lot of your EAP providers that might be really good providers on one level or the other, look for something that has financial health available for your people, or check into something like Financial Peace University or some option like that. That is definitely something that all of us in this world tend to worry about, is the financial side that can cause the other side to go south. So just consider that as well.
Love it. Kevin, any thoughts on that?
Just the networking. Network is huge. Get out to conferences as much as you can, develop your staff, send your staff to trainings. I've put it out there all the time, and that's when you find out what other people's resources are. So whatever you can do, there's many a year, some really great ones that you mentioned before.
Nice. A couple minutes left, guys. Closing comments. I can't believe we're at the top of the hour already. What an outstanding. I feel like I could talk to you guys forever, but unfortunately, we don't have that much time. And I do want to be respectful of everybody's time. Kevin, any closing comments today?
Sure. Thank you again. This has been honestly an honor of mine. I've followed Dr. Lilly and Jim's, I have the books, I have all the things here, and I'm learning so much from them. I think that taking some of these things that we've talked about today and trying to expand upon that over the course of the next year, while I come back and review what was my retention like. I've just wanted to just say thank you to them, but also to push that for those that are listening, say like, I don't know where to start. What can I do? Collective bargaining takes so long. Well, it wasn't easy. It took a long time. There was some hard conversations about it. People pushing for things, and you just got to like be that champion for them. Tell your boards and your higher level authorities that this is critical because, and factually list it out and kind of advocate for that, because it might not be an immediate turnaround, but in the long run, it will have a positive impact on your center and with your staff and with your colleagues. So thank you.
Excellent. And Kevin, thanks for being a part of this today. April, final comments?
I would kind of back up what Kevin said, but I would also say just like invest in your people. If you're a leader on here and you're trying to think about it, it's not going to change overnight, like Kevin said. So start planning now, start engaging your people, ask them what they want, what they need, so that you're not just doing something, that you think is going to help, but invest. That is like the first and foremost thing. And then I would say for telecommunicators on here, supervisors who are looking to their leadership, don't just look to your leadership, speak up. Tell them what you're needing. Start looking for resources, reaching out. There's plenty of peer support conferences that are out there. There are a lot of great clinicians. Obviously, Dr. Lilly and Jim on here. There's so much information. Reach out, gather that information, and take it to your leadership. That is so important.
Love it. Thank you, April. Dr. Lilly?
Yeah, I did my first 911 conference in 2012, and everybody was sitting there like this staring at me. And I had people tell me that I was going to ruin the industry by talking about PTSD.
Yes.
So holy moly, like
Yeah.
what a change in 12 years. It's awesome. I think that we or we'll focus on PTSD or depression, but I really like what April brought up early about, for example, financial counseling. So in the report that I'm writing right now, the number 2 issue among, and again, this was cops, but I see it 911 all the time, is financial stress. There's so much overtime and people work all this overtime, and then for whatever reason, they go out on medical or they have to take some time off or there's less overtime available. And all of a sudden they are experiencing very significant financial stress. And so there's lots of other factors besides just kind of mental health that contribute to stress that we really need to start having conversations about.
Well, thank you for being here today, Dr. Lilly, and totally agree. Mr. Marshall, you have the last word today, sir.
Well, I'll just say this. We have in our directors and our frontliners, our supervisors at all levels, we have a phenomenal group of human beings. The Noun family is exquisite in integrity. There's this, though. All of us have been guilty of not reading the instructions and trying to assemble something our own way. And when we do that, we end up having to figure it out and read the instructions eventually. Here's what I'm going to say. If you are dedicated to your people as leaders, if you are a follower in your center, but you're a leader by mindset, you must read the NINA standard to protect the well-being of noun professionals. Google it, the NINA standard to protect the well-being of noun professionals. If you haven't read that first, which was invested by not only people in NINA, but APCO International as well, if you haven't read that, you're going to be making it up without the instructions. Read the instructions and use all of your commitment, your devotion in a way that's going to be most productive. And I'm just grateful for the opportunity today. So thank you.
Awesome. Well, thank you, Jim, and a special thank you to my entire panel today. You guys have been great. We've actually, I'm looking at the number of people that are watching. I mean, a bunch of people hung on and wanted to hear closing comments. So I do want to give a quick shout out to Marie. Marie and I work very closely with Intrado to do things like this and provide these webinar resources to the community. So a big thanks to Marie for operating things in the background and making sure things work smoothly. The Share.Solve.Evolve webinar series, once again, is designed to identify topics within the 911 space and bring subject matter experts to the table to talk about a variety of different things. So we do meet on a monthly basis, so keep an eye out for our invites. More than likely, you're already going to be on the mailing list for future sessions, but please do keep an eye out for future sessions. And if you have ideas for sessions that you would like us, specifically topics to cover, feel free to reach out to me or any member of the Intrado team to let us know. But for everybody at Intrado, for Marie, and for my 4 amazingly excellent panelists, thank you all for being a part of Share.Solve.Evolve today, and have a wonderful Memorial Day weekend. Take care, everybody.